about telehealth. I'm going to be talking a little bit about kind of an introduction to telehealth and what we're seeing it do and how it can be used. And then we have two fantastic speakers, two of your network peers. We'll be talking about what they're doing with telehealth. So it's my job to introduce all of those. So you want to open my slide? So I'm Joe Wyvoda with Rural Health Innovations. Most of you have talked to me at one point or another, and you know that we're your technical assistance provider. Like I said, what I'm going to do today is talk a little bit about telehealth, give you an introduction to what telehealth is, give you some examples of how it's being used across the country in different ways that we've run into. I'll talk about some challenges and solutions to those challenges that folks have worked with. And then I'll introduce our two grantees. The two grantees will be Louis Winslow from the Rural Wisconsin Healthcare Collaborative, and he'll be talking about some of the experiences they're having with implementing telemedicine for behavioral health. A very nice example of how to implement and use end-to-end testing. And then we'll also have Regina Smith from the South Georgia Regional Prevention Coalition talk about their experiences with telehealth and using it with multiple providers, including schools. So let's start off by saying telehealth is not a new thing. It really has been around for quite some time. I love this picture. This is Neil Armstrong on the moon, and this is one of the earliest known uses of telehealth. They had all sorts of telemetry on the astronauts to monitor their vital signs, their cardiac activity in real time. This is in 1969. One of the first known uses of remote telemedicine, or at least telemonitoring. So it's been around for a while. Telehealth is a really, really broad topic. It's much more than just connecting to a specialist. It includes, things like home health monitoring, where you may have a patient at home that you want to monitor their blood pressure on a daily basis, or their weight to see if they're retaining any water, if they're a congestive heart failure patient. Home health monitoring is one aspect of telehealth. We're seeing telehealth being used in rural settings quite a bit for inpatient, emergency room, ICU, telestroke programs, all sorts of different ways that we're using it on inpatient units, so that you're seeing telehealth there. Behavioral health has been one of the delivery mechanisms, or one of the modalities of telehealth that has probably been one of the most popular that we've seen in the last few years. Behavioral health really doesn't need a lot of technology, and I'll talk a little bit about that for you to be able to provide those services. In particular, child psychology. There's a big shortage of child psychologists, and kids really have no problem interacting with technology, right? I mean, it's second nature now to them. So telebehavioral health has been something that really I see it as a boom right now. We're doing a lot of folks are using telehealth for behavioral health. Dermatology, cardiology, many other quote-unquote ologies are being provided over telehealth. A lot of these require specialized equipment, probably a higher level nurse or other care provider on the other end. Besides the cardiologist, for example, you might have to have a nurse that's specially trained. But these are telemedicine technologies that have been used quite frequently. Oftentimes they're done with a grant program, and there've been a lot of struggles with reimbursement for telehealth, and I'll mention some issues around that. Regardless, there's been strong evidence for how well telehealth works, how much money it can save for the payers for certain, and levels of customer satisfaction that have been really illuminating. That patients really like the opportunity not to have to travel. They like the convenience of it. Once they get over that hurdle, of wanting to be in the same room as the doctor, they oftentimes get used to it. And telemedicine has been shown to be very cost-effective, and it works really well. So there are a lot of resources that you can use that you should be aware of if you're doing anything with telemedicine or considering it. And probably the first one are your telehealth resource centers. These are federally funded organizations that are there to provide technical assistance to you for telehealth. And you can see that the country is broken up into regions, and you can see your state there and find your specific telehealth regional or telehealth resource center. They're very helpful for things like billing, technology, and they have great people. So I encourage you to go to telehealthresourcecenters.org, the website that's listed there, and contact your telehealth resource center. They can be very, very helpful and somebody that you absolutely need to be in touch with if you're doing telehealth. Another organization that I'll mention is the American Telemedicine Association. They put on a really nice conference every year, for one. That is a great place to see vendors. They put on a number of regional conferences too, and to hear speakers. They call themselves the leading telehealth association, and they are. They have a lot of industry research. And I put a couple of examples there of some research that have been released in just the last couple of months on their website. A lot of their stuff, you have to be a member to access it, but you can see the kind of examples of research that their members or the organization itself has put together. So using telemedicine around a pregnancy model to decrease preterm labor birth rate. What an interesting way to apply telemedicine, for example. They also have a lot of educational information and some practice guidelines. They have organizations, committees of folks that put together practice guidelines. So the best ways to deliver behavioral health, for example, over telemedicine. They have some fantastic practice guidelines. They're very in-depth. So that's worth becoming a member of ATA right there. They also have buyer's guides, which talk about different technologies and vendors. And I already mentioned their conferences. I attended their annual one this year, and it was a very big conference, not as big as HIMSS, if you've ever been to HIMSS, but still there were quite a few vendors there, really crossing the spectrum of telemedicine, everything from home health monitoring, remote patient monitoring, really across the spectrum of what you might need in telemedicine. So, and let's discuss a little bit of some of the common challenges that we see. One of them is interstate licensure. Providing care across state lines can be tricky, and we're seeing more, because every state has their own licensing program for physicians, for example. We're seeing multi-state compacts solving some of this issue. For example, Minnesota and Wisconsin are I believe, in a compact. The clinic workflow is one that has been a barrier in the past, and I think we've learned that lesson, but I still hear people struggle with this, where they'll implement telehealth by putting in a telemedicine room somewhere, and then they'll make an appointment for a patient in a rural hospital, and the provider who might be in an urban clinic setting will have to go a little ways across campus to go to the telemedicine room to do the telemedicine consult. That just is such a break in their workflow. So workflow and process redesign is very, very important here. You only get so much time with the physicians, and you can lose that physician engagement pretty quickly. Lewis is going to talk about their program and how they're doing end-to-end testing. And if you're implementing telehealth, it's really a best practice to do a really complete end-to-end testing approach. And I really like what Lewis and the folks in Wisconsin are doing. So he'll talk about that in a moment. Reimbursement continues to be a challenge in many ways. So you know, your Telehealth Resource Center, your TRC, will be able to help with that and give you some guidance. So reach out to your TRC. CMS does have some information on reimbursement and things to be aware of, and I included that link there. So feel free to copy and paste that, or you can always search for CMS telehealth information and you'll find it right away. Technology used to be a really big barrier. I think we've overcome that hurdle. You can use things like Zoom for providing telebehavioral health, for example. It's gotten significantly cheaper to do telemedicine. You don't need these more specific solutions that we were once putting in. So technology has gotten much easier. Most of the devices now, if you need a stethoscope, if you need a blood pressure cuff, many of them are available as Bluetooth devices, so that they'll work with just about any program. So technology barrier has really gone away. And with that, I'd like to introduce Louis Winslow. Louis is with the Rural Wisconsin Healthcare Collaborative, and he is going to talk about their project. So Louis, take it away.
Okay. Hi, everyone. Well, I'll just dive right into what we're doing here in Wisconsin. We started our process knowing we had many rural communities with almost no local access to behavioral health services, knowing we had significant behavioral health practitioner workforce shortages almost throughout the state, and believing that telehealth could play a major role in mitigating these issues. During our year one planning phase, we worked with a consultant from one of those resource centers that Joe mentioned. We performed needs assessments, identified practitioner resources within our network. We defined how the telehealth relationships would operate, which then led to the development of contracts identifying the roles and responsibilities of the network, the originating sites, and the distant sites, what we call patient facilities and provider facilities. In a nutshell, our paradigm is for the patient facilities to contract for blocks of time from the practitioners at the provider facilities. The provider facilities get paid an hourly rate. The patient facilities are responsible for the administration and billing of the services, both the facility and the professional fees, and the practitioners document into the patient facility electronic health records. In year two, we started working with 8 organizations, 4 of these patient sites and 4 provider sites, to implement that paradigm. This slide shows the 6 of those that are furthest along, with 2 patient facilities having gone live to date. Much of that has happened just in the last couple of weeks, and another one scheduled to go live by the end of the year. We currently have 2 psychiatrists from St. Croix, Wisconsin, providing psychotherapy and medication management services to patients in Toma. We have a psychologist in Ashland, Wisconsin, providing psychotherapy services to patients in the Dodgeville area, and an advanced practice nurse practitioner with a psych specialty in Baldwin scheduled to provide services to patients in both Dodgeville and the Baraboo area. So what are the things we've been doing to get from planning and contract signing to go live? Well, here's the list. Credentialing is a big ticket item, a significant challenge. Technology selection and implementation. We've started the process of working with payers to ensure reimbursement. We're developing and customizing workflows and protocols. There's lots of work relating to developing electronic health record documentation templates and educating practitioners on EHR use. And then the coordination of all this leading to formal testing of the workflows and eventually leading to go lives. We also know we have to work closely with network members to increase provider capacity. That hasn't been our focus through the pilot program go lives, but it's something we're going to need to get to very quickly. The next 6 slides are snippets from our implementation task lists. I'm not going to go into all of the detail, of course, but this gives you a little more of the flavor of what we've been doing. Starting with credentialing. For credentialing, there's the process of creating the credentials verification file to get the behavioral health practitioners credentialed and privileged onto the patient facility's medical staffs. And then there's the even trickier process of credentialing the practitioners with all of the patient facility payers. We had a credentialing service here at Rural Wisconsin Health Cooperative in place going into this project, which has positioned us to navigate the many challenges relating to this category of work. But we haven't really worked in telehealth before, so there's still a lot of intricacies that we're dealing with and learning from. Regarding technology, as Joe implied, that was probably the easiest part. Though still there are quite a few things to do here. Select, buy, configure, install, test, optimize, all those things. Luckily, the facilities all had decent levels of broadband, so we didn't have to do any broadband upgrades specific to this project. But that's the one area I think that could have created delays if we found that that was an issue. The next 3 slides are the nuts and bolts of thinking through the patient flow, from how the patient is referred into the service and scheduled. Just going to kind of go through these pretty quickly, to the details associated with the patient visit, including identifying the communication mechanisms between the remote practitioners and the local patient attendants, which so far have always been RNs in our pilot programs, to all of the things that need to happen at the end of the patient encounter and after the patient leaves. I think one hot button issue is how to handle prescriptions and specifically Schedule II meds, and we worked through those issues with every pilot. But I think the practitioner documentation piece in terms of the electronic health record is the heaviest lift on this list. That took a lot of resources. This slide gives you a sense of all of the coordination involved. It doesn't include 2 kickoff meetings we had in order to generate the implementation task list. We met first with the patient facilities to really define their goals without the practitioners being there, and then had a second meeting incorporating the practitioners, and out of those 2 meetings we developed our implementation work list. After the kickoffs, we had monthly check-ins to identify where everyone was on their tasks. We had an on-site visit to the provider facility for the patient facility staff to learn how the provider facility operates their own behavioral health program to inform their program development. And then eventually we had mock encounters and go-lives. You may notice that we postponed our go-live by several months after conducting our test encounter in this case, and that actually happened for both of our pilot programs that we've gone live with so far, and I'll talk about why that was in just a couple of minutes. Here's a slide with three of the workflow maps that were developed by the different participants. These are not really meant to be read. I don't want you to hurt your eyes. The point is that every facility is different with different electronic health records, different sort of internal ways of handling things and standard procedures, and no two workflows will be the same. So a lot of effort went by the participating facilities into developing these, tweaking these, and they're still in the process of improving them over time. And this is the one-page guidance document we developed to help facilities prepare for their test encounters. It starts with identifying an individual that will serve as the test patient and runs them through the designed workflow that they've developed. Each facility conducting a test or a mock run-through flesh this out and customize it to their specific situation, and that's what we used as the script for the test encounters. So now we're back to why we needed to postpone our go-lives in both of the pilot projects where we conducted our mock encounters. In one case, we had a technology issue involving two different instances of Epic, both deployed via Citrix. I'm getting a little wonky here, but the issue was that they weren't able to run on the same desktop, and the ultimate resolution was to implement a separate virtual desktop for the patient facility's Epic instance. But it took over a month for the provider facility's IT staff to get it done, and if we had had this happen during an actual patient visit, then the provider would not have had access into the electronic health record. So this is one of the reasons that we do this testing. In another case, we had the interesting situation of county services rather than primary care being the primary referral source. When primary care is the referral source, patient issues that happen between visits, such as the need for some kind of med adjustments, are usually triaged by primary care. During the mock encounter, it was identified that the county had lost the RN caseworker who was supposed to fill that role, and we needed to wait several months until they replaced the position before everyone felt comfortable going live and being able to take care of the patient, not just during the visit, but between visits. And then there were all sorts of other issues that came up during the mock encounters. Some of them education related, some of them workflow related, that required that protocols and workflows be tweaked prior to go live. So I think the lesson is test and test again to work out the major kinks. The results of doing this for us was that our go lives went relatively smoothly, as evidenced by the smiles in this last slide, perhaps slightly nervous smiles, but smiles nonetheless. There's still plenty of optimization for us to do, but I think everyone is comfortable that we were able to provide a good experience for the patient. Looking forward, we have processes in place to continue to optimize. We have a provider satisfaction survey that is filled out after every go-live with detailed questions of the behavioral health practitioner to identify anything they think we can do to improve. And then we have post-mortem sessions that I've been engaged in. Even today we had one to I get input from all of the other involved staff, and then from that we create a list of things we can do to get better. So I think that's about all I have. Joe, back to you.
All right, thanks a lot, Louis. Yeah, interesting stuff. Great job. And I know I already have some questions, but I'll save those to the end. And if I'll just remind people, if you have questions, feel free to type in the chat box. Otherwise, we'll try and save some time at the end for questions. At this time, I'd like to introduce Regina Smith from the South Georgia Regional Prevention Coalition. Regina, go ahead.
Thanks, Joe, and good afternoon, everyone. Thank you for allowing me just a few moments to talk to you today about what we're doing with telehealth from a grassroots level to increase access to health care for our children and families here in our local communities. I'll also talk a little bit about the barriers we've had to overcome and how we meet these challenges. I am pleased to let you know that by the time I get to the end of the presentation, I'll be able to end with a number of success stories. So let's begin a little bit with who we are. We are the South Georgia Regional Prevention Coalition. We are a regional prevention coalition serving a 4-county region in rural mid-South Georgia, which includes Bleckley, Dodge, Tattnall, and Turner counties. So we have a number of schools. We are a school-based health center clinic model. Our demographics in all of these counties are similar to many poor, rural, and underserved areas of the country. And our poverty and illiteracy rates and child abuse rates are among the highest. Our high school graduation rates are among the lowest in the nation, and our health indicators are among the worst. And all of our counties are officially designated as healthcare professional shortage areas. So you can see that we really had our work cut out for us as we started this project. Our coalition officially formed in January of 2000, and I don't know if many of you are familiar with the state of Georgia, but a number of years ago, 25 years ago, in fact, this month, our legislator allocated funds to build local collaboratives in each county, all 159 counties of Georgia. So that really helped in our partnership building and working together. We realized that we were not working in isolation within our county boundaries, and our local strategic plans were very similar to meet similar needs. And we have the same key stakeholders across county lines with community mental health, public health, law enforcement, all types of partners and stakeholders. So that just made sense for us to work together as a prevention coalition. And that's when we formed South Georgia Regional Prevention Coalition. Our mission is to work together toward a common purpose of building strong, safe, healthy, and drug-free rural communities where all of our youth and families reach their maximum potential and become productive citizens. We realize that access to health care can be a huge piece of this puzzle. Each year for the past 15 years, we've conducted an annual community needs assessment, and that helps us to determine the gaps in services to our children and families. We find year after year that our school systems do an outstanding job of educating our students academically, but many of our students still didn't have access to regular health care. The reasons for this are varied, but included in this fact is that we have a very limited number of providers, and we're also a bedroom community of Robins Air Force Base and Fort Benning. For that reason, many of our parents leave the county every day to work outside. So if to take a child to a physician, they must get off work. It takes pretty much an entire day by the time they come pick up the child and then drive 20 to 30 miles to see a physician. We talked about why we needed to find a way to increase access to health care, and when we began to dive into this, to determine that, we realized that all 4 of our counties were officially designated as healthcare professional shortage areas. Our county health departments were all overworked and underfunded. We only have 3 rural hospitals for the 4 counties. 2 of these are critical access. We have 1 regional medical center and a very few primary care physicians. We also have 14 school nurses for 24 schools. We realized that with these factors, many of our students didn't have easy, consistent access to health care, and therefore they did not receive the care that they needed. This is especially true in the area of mental health services. Each of our counties are at least 30 miles from a mental health provider, so there are no mental health providers in the counties that we serve. The intake time is lengthy unless there's a crisis. We do have a mobile crisis unit, and that is of great help when we need that. But our school nurses reported on the annual needs assessment that we have a large number of students who need regular mental health visits, follow-ups in order to monitor and adjust their medications. Our teachers regularly reported that a number of students would miss their regular appointments with their mental health providers and their medications would not be refilled. Of course, when this happens and a child misses a dose, he or she begins to exhibit behavioral issues as well as anxiety, and of course this all results in the inability to perform well in school. Telehealth is the answer to that for us, and it has been working really well. We also want to talk a little bit about how telehealth helped us to increase that access. It certainly helped us with acute care, specialty care, mental health, behavioral health issues, and as well we've been able to use it for training. Through the use of telehealth, we're able to treat acute illnesses such as ear infections, pink eye, rashes, and even determine when a student has head lice, which are all very common health concerns in a school system. This has offered regular and easy access to health care for many of our students during school hours and during the summer months. Another big advantage for our telehealth is that we're now able to offer specialty care. We work to negotiate a contract with Children's Healthcare of Atlanta to provide visits with pediatric cardiologists and other specialists. Again, let me reiterate that our counties are located approximately 170 miles from Children's Healthcare of Atlanta. We have very little, if any, specialty care closer than that to our counties. So the telehealth really helped to facilitate seeing a physician if you needed that for specialty care. The telehealth has also allowed us to set up initial mental health appointments and follow up on a regular basis to monitor and adjust medications as needed without the necessity for parents to take off work or to come in and travel at least 30 to 40 miles one way to follow up with those regular appointments. The telehealth carts allow us to complete training for our school nurses and school-based health center staff members. One area that has been most helpful in is learning about diabetic supports for students in our system, as well as last year there were new regulations on school systems having asthma inhalers available in the school systems, and we were able to use the telehealth to do a great bit of training on that. So that's another way that we've been able to use it. We did have some challenges. Of course, we started from the ground up, and again, I am not a healthcare provider. I am a school system staff employee, so we had to learn a lot. We had to rely on our partners. That's where it goes back to the coalition. When I opened with a little bit of the history about our coalition, we really work with our partners to help us and to help facilitate what we need to know. When we first began, we didn't even have written protocol the same and uniform throughout our school system for medical issues. And so one of our objectives in the Rural Health Development Network grant was to put together protocols for our new school-based health centers. We were able to work with public health to accomplish this and have our director of public health sign off on all of our protocols. That was certainly not a fast process. That was very lengthy. And then to get all of those protocols published and into the hands of our school nurses and our school-based health center staff. But now all of our schools have the same protocols, and they can administer medications and everything through a best practice method and know that they are following it correctly and doing it the way that it needs to be done so that we don't put our students at risk with something that we wouldn't know. While the concept of telehealth is not new, it was new to our school systems, offering a new level of access of health care rather than just what school nurses were accustomed to. And this was exciting for some of our school nurses, but it was also intimidating to some of the others. We had to overcome the challenge of time management. Our school nurses were overworked, so we had to build a sense of trust with that the telehealth could make this easier rather than harder once they got it started, but it did take some planning and some time management skills. Some of our school nurses were intimidated by the technology, and others were intimidated by the level of paperwork that was involved in obtaining parental consent and actually getting a student enrolled in the telehealth program. With specialty care, there's also another stack of paperwork that had to be completed before a child could be seen by a physician. We also had the challenges in getting parents to enroll their children in the school-based health center because they had never heard of telemedicine, and they certainly didn't know that the school now offered it. We were offering something new, and we had a great deal of work to do to promote this component of our school-based health center. We did know that it would take a lot of work to inform parents and get students enrolled so that we could ultimately provide increased access to health care for our students. but we also knew that it would be very worth it. We did learn in year one that we needed to send parental consent and enrollment packages home on the first day of school. This was particularly important, and we learned that the first year, because the first day of school is when everything goes home and parents are very conditioned to know that they will be completing paperwork. We also enlisted the assistance of our school attorney and an attorney that specialized in school-based health care to help us to make sure that the enrollment packages were correct and that they covered anything that we needed to be covered on, and that we were compliant on anything that related to FERPA or HIPAA violations, and would have that where we would be protected in that those particular areas. I would strongly recommend this, especially if you are a school system or if you're breaking new ground with your telehealth, because again, we didn't have those parameters of being a healthcare provider or in a hospital or in a healthcare setting. We were in a school setting. In billing and licensure issues, everyone gets excited about what telehealth can offer in the way of increased healthcare access for students. But as the project director, I also had to consider the business end of offering this component. These included costs for connectivity, Steph Connect license fees, and connectivity fees for our physicians in the network, especially our local physicians, because they were not part of a telehealth network. And they had to purchase equipment, and they had to sign on to pay the connectivity fees. And for many of them, this was a very strong financial commitment on their part to buy in that regard. The cost for connectivity can be as much as $500 or more per month for each license for each telehealth site. So depending on how large a school system is, or how many sites we had, or how many services we were providing, that cost can go up. So your school systems definitely need to be aware of that. And on top of the connectivity fees, we also had the Steph Connect fees through Littman or another provider. There was also the challenge of insurance paperwork and someone to do that work, and specialty care, of course, required even additional paperwork, and someone had to take care of all of that. So we had to look at what that cost would be. I am happy to say that we worked through these challenges in year one, and we have a very dedicated team, and much of the credit goes to them for not giving up or giving in when obstacles came along our way. Currently, our providers handle the billing of insurance companies for the telehealth services provided at our school-based sites. We have a number of providers that also serve indigent care patients when the need arises, so that these students can also be seen. But we don't do any billing at our school site currently. That is something that we may look at for sustainability. As we move forward with the equipment, we had a HRSA grant back in 2012, and that really set up all of our school-based health centers, and that was a great advantage because we were able to purchase the telehealth carts and systems for all of our sites. But we realized quickly that our school system infrastructure in some of our schools were not adequate to meet the needs of technology for this equipment, as well as some of our local physician offices in rural South Georgia. Sometimes we were in older historic buildings, and the connectivity issues and the telehealth technology issues were something to consider, and we had to redo some things in some of those buildings. Luckily, we had the buy-in of our local physicians and our school systems to take care of that. And I told you, I promised that we would end with a success story. We've come a long way since day one, where not many people knew what telehealth was in our communities and what could be made possible in the way of healthcare access for our students and families. And as I said when I started, we would end with a success story. And one that comes to mind today is the one of Charlie and CJ. Charlie and CJ are brothers, and they attend one of our elementary schools. Both had been diagnosed with ADHD. These children also had a situation in their home that prevented the parent from access to transportation, so they were not taken in for regular follow-up appointments to monitor or adjust medication. Charlie was failing first grade, and both he and CJ both were in and out of the principal's office with behavior marks. Attendance was also an issue due to medications not being monitored regularly. The social worker made a home visit and obtained parental consent and the necessary forms to enroll both Charlie and CJ in the school-based health center. In the center, they were able to have the school nurse set up regular monthly visits with their healthcare provider, which monitored and adjusted their medication so they could function well each day at school. And both were promoted this year, and they're doing well. Because of the Rural Health Development Network grant and telehealth medicine component, we're able to share success stories like this. So thank you for your time today, and if there are any questions, I'll be glad to answer them, or I'll have my contact information here, and you're welcome to contact me directly and we can chat. Thank you so much.
Thank you, Regina. That was very interesting. Well done. And thank you, Louis. We do have some time for a few questions or discussion. I don't see anything in the chat box. If you'd like to ask a question over the phone, feel free to ask away. Don't forget to do *2 to unmute your line. And Louis, I wonder if you could just take a moment to maybe expand a little bit on how you were doing the end-to-end testing, because I don't know if people really, or what do you call it? You call it a mock encounter. I don't think a lot of people really appreciate how deeply you're doing those mock encounters. Can you tell us kind of what it was like?
Sure. Well, we emphasized the need for this early in the process, and our goal with everything we did was to work toward readiness for testing the workflows we had created. So the mock encounter day really had a lot of preparation going into it. There was all the months and months of work to identify the process and the workflows, and then there was taking that list of different things that we wanted to do that day and making it specific to your organization. So every organization had someone that was responsible for doing that. They did identify a test patient, and then, you know, it was actually kind of exciting. It felt like a real encounter. In one case, we were at the patient facility. We had several network staff there. We had many of the patient facility participants, probably 5 that had been involved in the planning, and then we also had 2 representatives for county services all participating. And it started, you know, kind of just like it's listed on that slide. The designated patient was registered, and they went through the registration process. The goal was to have the patient come with a filled-in intake form, and that sometimes happens in the real world, and sometimes they come in without one. But in this case, the test patient came with an intake form, and the organization had to ask, at what point do we scan it in to make it available to the practitioners for viewing during the patient visit? Do we do it at point of registration, or does it happen in the next step? So the next step would have been for the patient who was registered to be called in to the room with the patient attendant, basically the nurse, to do their intake, where the nurse takes their vitals, documents their piece of the encounter, potentially scans in additional information, and prepares the patient to be seen by the behavioral health practitioner. And then we move on to the next phase, which is that video encounter with the behavioral health practitioner, which happens in a different room. That's also, there we didn't really have an encounter the way you would have with a real patient. We had already tested sort of the visuals and the sound long before that, but we kind of spent the time to discuss all the EHR documentation issues with the practitioner. They went into the electronic health record, viewed all the information that had been made available by the attendant, and basically acted as though they were seeing the patient, making sure they had that information available. After that part was complete, generating the discharge instructions, any medications that needed to be ordered, making sure they understood how to order lab tests. You know, in that case, we had practitioners using one EHR in a system that wasn't the one that they were used to. So those challenges become magnified. It was very important for us to have detailed education documents for them to help guide them in terms of how to use that electronic health record system. So we tested those as part of that process, and then they needed to document the patient encounter. I'm not going to get into all the details of all the little blips along the way, but it took us the first time it took us probably an hour and a half to get the patient out of the intake attendance room because of all the issues that came up, down to, like, is the intake form being scanned in the right way? You know, all kinds of issues came up. And then with the practitioners, it was kind of even more intensive. You know, the billing piece, we actually didn't do as part of that. That happened kind of behind the scenes by others later. But we did all sit down at the end of that encounter, discussed how everything went, and then my goal was to confirm we were going live in 2 weeks. And I really pressed the organizations to say, yes, we want to do that. But that's the case where they decided we're not sure that we have the resources we need to take care of the patient between visits. So until we address this one problem, we're going to hold off. So that's kind of one story. I have others, but they're all nuanced and different, and everyone types up notes afterwards that we put together. But really, that's the process that we use to clean up many of the issues. And then in that case, we had a second mock encounter when we asked that same question at the end of it, are we ready to go in a week when the first patient is supposed to present? And everyone said, yes, let's do it. We went live, and it went well.
Great. Yeah, and thank you for elaborating on that, Louis, because I think that a sure way to lose physician engagement is to have it fail repeatedly. And by doing all of that work, you're really trying to avoid that as much as possible and making the process as smooth as possible. So excellent. Thank you for elaborating. Regina, I'd like you to maybe address Sally's question about how did you identify the providers who could provide the services to the outlying facilities? That's a great question.
Great, thank you, Joe. One of the ways that we identified providers was through the Georgia Partnership for Telehealth Network. Again, we purchased our telehealth carts from the Georgia Partnership for Telehealth and bought in part of our connectivity fees is to be a part of that network. Again, because we have very few local physicians. We did, however, we worked really, really hard with a couple of our local pediatricians because they serve probably 75 to 80% of the children in our school system because they're local and everyone knows that pediatrician. So when a parent would come in, they wanted that pediatrician. They wanted their child to see their same doctor. So we worked with those two local pediatricians and were able to get both of them to purchase their own equipment and buy in. And again, we had to go through all the setup to make sure that it was working and the mock patient trials and things like that to make sure that the equipment was working. We had some infrastructure issues that I talked about with our connectivity. We needed to upgrade, and very fortunately for us, we had those physicians that would do that locally, as well as those physicians in the network who had already bought into serving the network in Georgia.
Okay. Are there any qualities that of the providers that you thought were important, for those to be able to participate in telehealth?
Well, again, we have so few providers locally. We did think it was very important to have those pediatricians. Two of the 4 counties have pediatricians that do see a large number of students. We're located very close together, but we did want physicians that had good references, especially in a network if we were connecting to a physician that we didn't know anything about. So we worked really hard. Our school-based health center coordinators worked really hard to build those relationships with those physicians and their staff and within their offices so that the visits would go smoothly. And we wanted the willingness to work with us because we were new and we didn't know a lot, and we needed a physician that would be patient with us.
Okay. Thank you. And then I don't know if either one of you want to address Jack's question about expanding on the work needed to assure your programs will get payment from insurers. I don't know, Louis, if you want to start on that?
Sure. Well, one thing we did early on was we developed kind of a little Excel tool, it's a little fancier than that modeled out potential reimbursement by insurer categories, so Medicare, Medicaid, commercial pay, and then we looked at it from the different practitioner types, psychiatrist, psychologist, APNP, and physician assistant, and we looked at, what the fees were likely to be. We researched who was likely to pay, and then it allowed them to get a sense of, the potential ROI. And I think in this field, the ROI is, I'm not sure, operating a very streamlined service with very low no-show rates, which is very difficult to do with this patient population. It's very difficult to operate profitably. The issue, I think, though it's possible, but the issue really is to find other returns on investment. Things like, primary care provider satisfaction with being able to get the input from the behavioral health practitioners, patient satisfaction, doing good for the community, those types of things. But in terms of your specific question, credentialing is the first thing. We weren't concerned about Medicare and Medicaid. The research we had done, and we spent a lot of time working with Medicaid to sort of clarify this. I won't believe it until they actually start getting paid. Now that we've gone live, we're monitoring this very carefully. But we expect that with our model, they will get paid what they're supposed to for Medicare and Medicaid. Now, the issue with Medicare is it needs to be in a rural location or in a mental health HIPSA for that location to qualify. So with that caveat, we were comfortable that our model would allow the patient sites to get paid. Now, with commercial payers, it's a whole different story. That is a case-by-case issue, and we did significant research and we have a lot of payers in Wisconsin and a lot of provider-based payers, and some of them we knew would pay from our communications with them for this type of service. Others, it was murky, and others indicated they wouldn't. So my perspective on that is, if you have just a few big payers in your state, it's probably an easier process to determine, whether or not they'll pay for the service. When you have many of them, some will, some won't, and our perspective is that once we determine who are the good players who will pay and who are not, then part of our work is going to be to work with those payers that aren't reimbursing for the service and advocate on the behalf of the importance of doing so to support our sustainability model and for the benefit of rural patients. So I don't know if that clearly answers your question, but it's my perspective on it.
Thanks, Louis. And we're just about out of time. We do have a couple of other announcements that we want to make. Sally had asked if you'd be willing to share that template, Louis. Is that something that you'd be willing to share?
Oh, yeah, I'm happy to share that Excel document. I'll send it to you, Sally, right after the meeting. If not then soon. The only issue there is, Medicaid, our modeling is based on Wisconsin, of course. And there's some tricks to it, so you may have questions or you may want to talk to me about it once you get it.
Thank you. Yeah, if you want to send that to me, Louis, then I can distribute it to folks as well.
Okay.
Great, and Regina, thank you, and Louis for an excellent job on the webinar today. This was fantastic, and I'd like to send it back to Cassie for a couple of announcements. Cassie?
If you could just take a few minutes to fill out our survey here, and I'd like to remind everyone about the Development Partnership meeting on October 19th and 20th. If you haven't signed up for the meeting, we do have a link on the screen where you can sign up. If you would like to attend, please sign up by October 11th. And even if you're not attending, if you could please send maybe 3 or 5 slides kind of showcasing your network, and you can send that to the network TA email, and Jane would like to have a recurring slideshow going on during the meeting to show everyone's network. And that's all. Thank you guys for attending.
Thanks, everyone. Have a great day.
Bye, Joe.